Mansoura University. Today we are going to talk about thin gingival phenotype augmentation around dental implant in aesthetic zone. Aesthetics has been a directing force in dictating the direction of progress in implant dentistry for the past decade. Papilla loss, plaque triangle, facial gingival recession are the term used to describe aesthetically challenging situations surrounding dental implant. The anatomic difference between peri-implant soft tissue and that of the natural teeth showed that maintenance of soft tissue profile around dental implant is more difficult because of the difference of the vascular supply, the arrangement of gingival fiber, and the fiber type around the dental implant. Nowadays, also, it has been found that the existing gingival phenotype play a very important role in the determination of the final treatment plan to overcome any possible future complications. Olson and Linda subdivided periodontal tissue into two main categories, thin and scalloped or thick and flat periodontium. There has been a lot of debate whether there is a need for presence of adequate attached soft tissue around the dental implant. Finally, they have correlated the presence of attached tissue with an improved soft tissue health, prognosis, and patient satisfaction. Few procedures can be performed to enhance the gingival phenotype. One such procedure is the use of connective tissue graft. Another mode of enhancing the gingival phenotype is by the placement of platelet-rich fibrin membrane, which is one of the most recently used platelet concentrates. One of the most desirable features of platelet-rich fibrin is its efficacy in providing concentrated growth factors at the surgical site to stimulate the healing process. PRF is considered as a healing biomaterial, and it has a stimulating effect on various aspects of healing of soft and hard tissue, including angiogenesis and immune control. The aim of this study was to assess the efficacy of PRF in comparison to subepithelial connective tissue graft and the management of thin gingival phenotype surrounding dental implant within the same patient and the same arch. 20 patients who were seeking replacement of missing teeth at the maxillary anterior and premolar area using dental implant were selected, putting in our concern the following inclusion and exclusion criteria. Inclusion criteria: provision of informed consent more than 21 years old, 2 or more missing teeth in maxillary anterior and premolar area, patient with thin gingival phenotype, gingival thickness was less than 1.5 millimeters. Exclusion criteria: untreated rampant caries, insufficient interocclusal distance, heavy smokers, uncontrolled diabetes mellitus, and pregnancy. Study design: patients were classified into two main groups. A study group, which include 10 patients seeking for implant placement at 2 sites in the upper anterior and premolar area with thin gingival phenotype. Implants were placed with the application of PRF in one side and the application of subepithelial connective tissue graft at the other side. Control group: it includes 10 patients seeking for implant placement at upper anterior and premolar area with thin gingival phenotype. They received their implant without any soft tissue augmentation. Methodology: clinical examination and preoperative measure. Complete medical and dental histories were taken from all patients. Then the planned surgical site were assessed for mesiodistal and buccolingual dimension of the surgical site and the facial gingival thickness from the cone beam CT taken at the baseline. Study group: subepithelial connective tissue graft site. Firstly, the surgical phase, implant placement. Here we can see 2 missing upper central incisor. This is after flap reflection. And this is the drilling, parallelism checking using parallel pin, harvesting subepithelial connective tissue graft, application of subepithelial connective tissue graft in the front of dental implant placed, and after suturing. Study group: PRF site. This is after reflection of the flap, drilling, the osteotomy site, parallelism checking using a parallel pin, implant placement, blood sample collection, centrifugation, PRF gathering from the patient, application of PRF in the front of dental implant, and after suturing. Prosthetic phase: this is 6 months after implant placement using a healing abutment, final abutment and impression taking. And this is 6 months and the final contour after healing abutment removal. This is the final prosthesis. Radiographic phase: this is a periapical radiograph taken immediately at the prosthetic phase, and this is 3 months after prosthesis placement, showing a slight amount of crystal bone loss here and here. This is the cone beam CT taken at the baseline and the cone beam CT taken 6 months after implant placement, showing a slight increase in the facial gingival thickness in the front of dental implant using BRF and using subepithelial connective tissue graft. Periodontal assessment. The following criteria were evaluated for all patients once after 6 months from implant placement and again after another 3 months. Implant stability assessment. Implant stability was evaluated by recording the ISQ level measured by Ostel device at the time of implant placement, T0, and at the time of prosthetic phase. Soft tissue assessment. Soft tissue assessment was conducted 6 months after implant placement and 3 months after prosthesis placement, which included the following: modified Black Index, peri-implant periodontal probing depth, modified sulcus bleeding index, the Benke aesthetic score assessment, showing the 7 variables as we know here. Case presentation, case number 1. This case shows replacement of 2 missing upper central incisors, and this is the application of subepithelial connective tissue graft, the application of platelet-rich fibrin, and after prosthesis placement. Case number 2. This case shows replacement of 2 missing upper lateral incisors, and this is after application of PRF. This is after application of subepithelial connective tissue graft and the final prosthesis placement. Table 1 shows the demographic data and the thickness of the facial gingiva of the study groups at the baseline T0. There was no any significant difference between the study and the control group patients as regard to age, sex, and the thickness of the facial gingiva at the baseline T0. Table 2 shows the thickness of the facial gingiva of the study groups at the baseline T0 and 6 months after implant placement. There was significant difference between the thickness of the facial gingiva in all groups. Also, there was significant difference between both sides of the study group and the control group patients at all points of assessment at T1. Table 3 shows the clinical periodontal parameters of the study groups 6 months T1 and 9 months T2 after implant placement. There was significant reduction in all periodontal parameters in both sides of the study group and the control group patients. Additionally, at T2, there was high significant difference between control group and BRF group. There was high significant difference at T1 and T2 between subepithelial connective tissue graft and the control group. Moreover, it was found that at T1 and T2, there was high significant difference between both sides of the study group patients. Table 4 shows the austere reading of the study group immediately and 6 months after implant placement. There was high significant difference at the side of PRF. Additionally, there was high significant difference between the PRF side and the control group patients and between both sides of the study group patients. Table 5 shows the amount of crystal bone loss around dental implant placed in the study group 6 months after implant placement. There was high significant difference between the PRF side and the control group patient and between both sides of the study group patients. Table 6 shows the Benke aesthetic score of the study group 6 months and 9 months after implant placement. There was high significant difference in both sides of the study group and in the control group patients, with much improvement in the subepithelial connective tissue graft side, followed by BRF side, then the control group patient. Based on the result of this study, it can be concluded that both BRF and subepithelial connective tissue graft can be used in patients with thin gingival phenotype with superior result regarding to the final aesthetic outcome with subepithelial connective tissue graft compared to the BRF. BRF improved the hard tissue conditions around the dental implant placed more than subepithelial connective tissue graft. BRF can be used instead of subepithelial connective tissue graft in the management of patients with thin gingival phenotype, as there is no need for second surgical site, less time consuming, less technique sensitive, and less patient morbidity. Recommendations: further research is required to study the effect of timing of soft tissue graft, either before, during, or after dental implant placement. Longer follow-up period and a bigger sample size can be used. Thank you for your attention.
Thank you very much, Dr. Ayman.
Thank you, Dr. Karim.
I open now the floor for questions for the jury, judges.
I'm Dr. Ilham. I would like to ask a question, please.
Okay, fine.
Concerning the abstract, it was mentioned the thickness of facial gingival tissues were assessed using CBCT. Can you please
Yes.
elaborate more on this point?
Yes, we made cone beam CT at the baseline firstly to determine the amount of POON, firstly to determine the diameter and the length of the dental implant, and also the facial gingival thickness was determined using the cone beam CT by taking cotton rolls in the labial sulcus to separate the gingiva from the facial gingiva and to determine the accurate thickness of the facial gingiva during taking a cone beam CT.
I have actually a concern about the accuracy of the methodology. The second question is in how did you make sure that there is accurate interdental space between the two teeth that were taken in the same patient, the standardization?
Standardization, yes. We make standardization for the amount for the distance between the two natural teeth. Okay. Before in the pre-operative examination, we make standardization during this procedure that the length between the two natural teeth should be in the normal range, which is 7 millimeters from the natural tooth to the center of the dental implant and to the other implant.
Thank you. I have no more further questions.
Thank you, Dr. Ilham.
Thank you. I have questions for you, Dr. Ayman. My first question is about the last point Dr. Ilham was mentioning. If you have two neighboring teeth implants, you did one with subepithelial connective tissue graft and the other with PRF.
Yes.
But they were beside each other. Can you exclude the effect of the PRF on the adjacent side, on the subepithelial?
Yes, we wait for 3 weeks before making the second surgery. We place firstly the.
Why especially 3 weeks? Is there a reference for this time?
Yes, there is a reference that there is 21 days that the BRF gives his growth factors in this time, 21 days.
Okay. My second question is about the sample size. Did you do a sample size calculation for your 20 patients?
Yes. The sample size calculation we made, firstly, it gave us 7 patients only, and we make extra cases for more 3 patients to complete it for 10 patients.
So you should have 30 patients, not 20, because you have 3 groups.
No. This split mouse design, there is a reference for this also. We make that split mouse design is divided into 2 groups within the same group. We make subgroups in the same group.
And what was the primary outcome? You calculated the sample size accordingly?
What?
Which was the primary outcome you used to calculate your sample size?
Statistically, we make it statistically.
What was the primary outcome you used? The outcome. You use an outcome to calculate sample size. Do you know what primary outcome you used?
I don't know.
Okay, I have the last question. You found out that there is a significant difference in the plaque, in the bleeding, and in the implant stability between the subepithelial connective tissue graft and the PRF.
Yes.
Do you have an explanation for why there should be a difference in plaque as well as in bleeding and implant stability? Do you have an explanation for this?
I see that this is for the increase of the thickness of the facial gingiva due to using subepithelial connective tissue graft more than the BRF, gave us more adequate attached tissue and more seal around the dental implant. So it reduces the plaque accumulation and reduce the bleeding also, and improve oral hygiene measures that the patient can make.
Okay, thank you very much. I have no further questions.
Thank you, Dr.
From the jury?
No, Dr. Karim. I think we're also running out of the time.
Yes.
Okay. So,
thank you very much, Ayman.
Thank you, Dr. Karim. Thank you a lot. Thank you.
Dr. Karim, you can close this session to move to the other, please.
Yes, we thank you all, Dr. Ayman, and we thereby close the session, and please move to the next one. Thank you all very much.
Thank you.
Thank you, Dr. Karim. Thank you.